connecting to the internet because he is in a province. They are doing inspection of schools.
BG, you introduced the channel one in representative for in Malaysia.
Yeah. Yes po.
Alasutlang dagat at ang bayan niyang pinili nasa dulo ng bahaghari, kaya't 1,000 kulay nangangakit kumakaway. Piliin mo rin ang Pilipinas, kapulo ang kwintas ng perlas. Piliin mo, yakapin mo, kayamanan niyang likas. Piliin mo ang Pilipinas. Kasayahang di mapatid, ramdam sa bawat awit. Sama't silisig lang indah, mga puso'y lumilipad. Piliin mo rin ang Pilipinas, kapulo ang kwintas ng perlas. Piliin mo, yakapin mo, kayamanan niyang likas. Piliin mo ang Pilipinas. At ang ngiti ng may kapal, taglay ng bawat nilalang. May lambing na tumutuyan sa buong pakiramdam. Piliin mo rin ang Pilipinas, kapulo ang kwintas ng perlas. Piliin mo, yakapin mo, kayamanan niyang likas. Piliin mo ang Pilipinas.
Every day, the Philippines does more than wait. Putting together new adventures. And experiences for you to try. We're making our sites better for you to see. Cooking up new dishes for you to taste. And preparing cultural discoveries for you to feel. And we're not stopping. Because we know that you deserve more. We can't wait to welcome you.
Organisasyong part ang itinatag para sa aming mga radtek ng bayang liyag. sa aming patuloy na paglinang ng kaisipan at pag-unlad ng panahon ay sabayan. Ikaw, ako, sila tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mangaratek sa bansang Pilipinas, nating sinisinta. Si Rowen, Jen, ama ng aming profesyon, liwanag na hatid, dala niya ay pag-asa. Ang teknolohiko, radyolohiko, tungkulin ko sa bawat tao. Ikaw, ako, sila tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mangaratek sa bansa Pilipinas, nating sinisinta. Isigaw at magsaya, mangaratek ay mahalaga. Profesyong teknolohiko, radyolohiko, ipagpunyi natin sa mundo. Ipagpunyi natin sa mundo.
Minsa'y natuwa ang may likha, 7,000 pulo ang ginawa. Mga hiyas na inilatag sa malasutlang dagat. At ang bayan niyang pinili, nasa dulo ng bahaghari. Kaya't 1,000 kulay nangangakit kumakaway. Piliin mo rin ang Pilipinas, kapulo ang kwintas ng perlas. Piliin mo, yakapin mo, kayamanan niyang likas. Piliin mo ang Pilipinas. Kasayahang di mapatid, ramdam sa bawat awit. Sa masisiglang inda, mga puso'y lumilipad. Piliin mo rin ang Pilipinas, kapulo ang kwintas ng perlas. Piliin mo, yakapin mo, kayamanan niyang likas. Piliin mo ang Pilipinas. At ang ngiti ng may kapal, taglay ng bawat nilalang. May lambing na tumutuyan sa buong pakiramdam. Piliin mo rin ang Pilipinas, kapulo ang kwintas ng perlas. Piliin mo, yakapin mo, kayamanan niyang likas. Piliin mo ang Pilipinas.
Every day, the Philippines does more than wait. Putting together new adventures. and experiences for you to try. We're making our sites better for you to see. Cooking up new dishes for you to taste. And preparing cultural discoveries for you to feel. And we're not stopping. Because we know that you deserve more. We can't wait to welcome you.
Organisasyong part ang itinatag para sa aming mga radtek ng bayang liyag, sa aming patuloy na paglinang ng kaisipan at pag-unlad ng panahon ay sabayan. Ikaw, ako, sila tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mga radtek sa bansang Pilipinas, nating sinisinta. Si Rowen Jen, ama ng aming profesyon, liwanag na hatid, dala niya ay pag-asa. Ang teknolohiko, radyolohiko, tungkulin ko sa bawat tao. Ikaw, ako, sila tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mga radtek sa bansang Pilipinas, nating sinisinta. Isigaw at magsaya, mga radtek ay mahalaga. Profesyong teknolohiko, radyolohiko, ipagpunyi natin sa mundo. Ipagpunyi natin sa mundo.
Minsa'y natuwa ang may likha, 7,000 pulo ang ginawa. Mga hilyas na inilatag sa malasutlang dagat. At ang bayan niyang pinili, nasa dulo ng bahay.
Organisasyong part ang itinatag para sa aming mga ratek ng bayang liyag, sa aming patuloy na paglinang ng kaisipan at pag-unlad ng panahon ay sabayan. Ikaw, ako, sila, tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mga ratek sa bansang Pilipinas, nating sinisinta. Si Rowell Jen, ama ng aming profesyon, liwanag na hatid, dala niya ay pag-asa. Ang teknolohiko, radyolohiko, tungkulin ko sa bawat tao. Ikaw, ako, sila, tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mga ratek sa bansa Pilipinas, nating sinisinta. Isigaw at magsaya, mga ratek ay mahalaga. Profesyong teknolohiko, radyolohiko, ipagpunti natin sa mundo. Ipagpunti natin sa mundo.
Hi everyone from Asia and all over the world. This is CPD Asia, online continuing professional development platform for Asian radiologic technology societies. Hosting the 14th CPD Asia is the Philippine Association of Radiologic Technologists, PART, and I am Peachy Luna, your program host. We are again grateful to our sponsor, VT Healthcare Vietnam, in helping us organize the online CPD Asia. And we are live streaming on YouTube. Please search VART and PARI channels. So you may join us live and watch a replay using the YouTube channels. This online Asia CPD is highly supported and graced by member societies' presidents, the officers and representatives. Allow me to recognize them and let us greet and welcome President of Macau Radiologic Technologists Associations, MRTA, Fernando Koch.
Hello, good evening, everyone.
President of Indonesian Society of Radiographers, or PARI, President Giek Sugianto. We also have President of Vietnam Association of Radiological Technologists, VART, President Thai Van Loc.
Hello, everyone. Hello, good evening, everyone.
We also have the President of Hong Kong Radiographers Association, HKRA, President Wan Shiu Bun Nelson.
Hello, everyone. Good evening.
We also have the Singapore Society of Radiographers, SSR President Denise Chung. We have also the representative of Myanmar Society of Medical Radiation Technologists, Yin Yin Tan. We have for Malaysian Society of Radiographers, Mrs. Chan Lai Kwan. And we have President Sophie Lee of the Association of Cambodian Radiological Technologists. And for President Rolando Banares, PART Vice President, Mr. Dexter Rodelas.
Good evening, guys.
Thank you very much, dear presidents and officers. And later, they will be joining us again during the Q&A session as our panelists. So may I humbly request all presidents, officers, guests, and speakers to please open your camera for a short photo session. All right, thank you very much. Now, to formally start the program, please welcome the Vice President of the Philippine Association of Radiologic Technologists, PART, Vice President, Mr. Dexter Rodelas.
Good evening, guys and friend. I welcome all of you to the 40th CPD Asia online continuing professional development platform for the ASEAN Radiologic Technology Societies. We hope that you will be able to learn and appreciate the discussions that our speakers will discuss in the program. We thank you all, the President, and everyone for being here today. Thank you and mabuhay.
Thank you so much, Philippine Association of Radiologic Technologists, Vice President, Mr. Dexter Rodelas. So this CPD Asia has two speakers, lecturers. The focus of their lecture is about actionable critical findings in imaging the chest and abdomen. We shall be having our Q&A session after our discussions. And meanwhile, you can type your questions by clicking the Q&A button in Zoom or type in your questions in the chat box. For those who are in the live broadcast via YouTube, you can also chat your questions there, and we'll hope and try to accommodate all your queries. So allow me now to briefly introduce our speaker. Our first speaker, Dr. Gerald Garvin C. Lim, is a board-certified radiologist and a fellow of the Philippine College of Radiology. He obtained his medical degree and postgraduate internship at the University of Santo Tomas, Faculty of Medicine and Surgery in 2015. He then had his residency in general diagnostic radiology at St. Luke's Medical Center, Quezon City, and has recently concluded his fellowship in CT-MRI, CT-MR imaging in the same institution. He has presented various case discussions and research papers both locally and abroad. His special interest dwells in cardiothoracic imaging, and he will be talking about critical findings in the chest in this session. Please welcome our first speaker, Dr. Gerald Garvin C. Lim.
Good day, everyone. I'm Dr. Gerald Garvin Lim, a CTMR Imaging Fellow, and I'm here today to discuss about critical findings in the chest. I have no relevant disclosures pertaining to this talk. My objectives are to define critical results and to enumerate select critical findings in the chest, with emphasis on radiographs and cross-sectional imaging. So critical result is defined as any result or finding that may be considered life-threatening or that could result in severe morbidity and require urgent or emergent clinical attention. Each facility has leeway to define its own critical tests and results, and thus there is really no standard list for either category. But what is essential is that it requires rapid communication of results, whether normal or abnormal. So now we tackle the critical findings in the chest. First one is pneumothorax. It's basically air within the pleural space and is most commonly from rupture of subpleural plebs. As you can see, the tiny lucencies at the periphery of the collapsed lung. It most commonly occurs in 20 to 40-year-old males who are asthenic and are smokers, and is characterized by acute onset of pleuritic chest pain, dyspnea, or back or shoulder pain. On chest radiograph, in an upright position, these are the radiologic signs. You will see an area of lucency with no pulmonary markings. It's pointed by the white arrows. And these represent the air in the pleural space. The yellow arrows, meanwhile, point to a thin white visceral pleural line associated with lung collapse, which is the single best sign for pneumothorax. The red arrow points to a depressed left hemidiaphragm. And these are the classic findings, and this is easy to identify, especially when the pneumothorax is massive. But what if the patient is in a supine position? Will you still see these classic signs? Well, yes, especially when the amount of pneumothorax is moderate or large. The problem is when it's minimal, and the picture may look differently. So in a supine position, air may go to different spaces. So if the patient is lying down, the air will go to the anteromedial portion, and this is the earliest location. So the pneumothorax may not display the classical signs. Instead, the pneumothorax may be demonstrated by looking for the following signs, namely the outline of the medial diaphragm under the cardiac silhouette and the deep sulcus sign. This is a pneumothorax in the infrahilar anteromedial space due to vehicular trauma. You see in the supine radiograph, there's a sharp delineation of the left heart border and the deep anterior cardiophrenic sulcus, while the corresponding axial CT of the lung base shows substantial air collection in the pleural cavity at the anterior cardiophrenic sulcus. In a supine patient, air may also outline the anterior portions of the hemidiaphragm and cause visualization of the anterior claustrophrenic sulcus, when both the diaphragmatic dome, which is outlined by the white arrow, and anterior portions of the diaphragm, outlined by the pleural air, as depicted by the black arrow. If both of these are visualized, the double diaphragm sign is produced. The second most common location is at the subpulmonic space, as in this case of a middle-aged woman with interstitial pneumonia. Supine radiograph shows a hyperlucent upper quadrant of the right abdomen, and corresponding coronal CT image clearly depicts the inferior surface of the lung, a sharply outlined diaphragm, an IVC, and a deep sulcus sign as well. This pneumothorax, meanwhile, is in the posterior medial space of an elderly man with chronic obstructive pulmonary disease. A supine radiograph shows a lucent triangle with a partially collapsed left lower lobe. Corresponding CT image of the lung base shows pneumothorax in the posterior medial space, and the left inferior pulmonary ligament, which is the linear structure between the mediastinum and the left lower lobe, is clearly visible. This is a pneumothorax in the apicolateral space of an elderly male due to esophageal perforation caused by endoscopy, which resulted in pneumomediastinum, pneumothorax, and subcutaneous emphysema. This is a supine radiograph with corresponding coronal CT images showing the visceral pleural line in the apicolateral space, the pneumothorax in the intermedial space and subpulmonary space, pneumomediastinum, and subcutaneous emphysema are also visible. There are no vascular markings that exist beyond the visceral pleural line. However, there are potential mimics for pneumothorax, so you have to be careful, and here are some examples. This is an elderly male with sepsis. You can see that there is a linear opacity nearly parallel to the right chest wall extending from base to the apex. Here's a closer view. The lung marks are evident peripheral to this line, implying that this is not air in the pleural space. This is actually a skin fold. Skin fold is usually mistaken as visceral pleural line, and they typically occur in the elderly with loose skin. And to differentiate the skin fold and pneumothorax, absence of increased lucency laterally and demonstration of lung markings across a curvilinear shadow likely represents skin fold. Now in this image, it is focused on the left upper chest and can see a white line shown by the arrows. Could this be a visceral pleural line? The answer is no. This is the edge of the scapula, and you can easily follow the contour of the scapula to make sure it does not project over the chest. In this image, there's an area of lucency in the right upper lobe that is devoid of pulmonary vascular markings. This looks just like a pneumothorax. There is also white linear opacity shown by the yellow arrow that looks like a pleural line. This is actually bullous emphysema. Distinguishing pneumothorax from bullous emphysema can be difficult, but it is important to distinguish them since management may vary. Now in a tension pneumothorax, air from a ruptured lung enters the pleural cavity without means of escape, and as air pressure builds up, the affected lung is compressed and all of the mediastinal tissues are displaced to the opposite side of the chest. In cases where classic features are not clearly present, a number of techniques can be employed, such as the lateral decubitus radiograph. It should be done with suspected side up. The lung will then fall away from the chest. So if the suspected pneumothorax is on the right, the right chest should be up. That is the left lateral decubitus position. Inspiratory and expiratory projections are one technique that can be used to make a pneumothorax more obvious. In expiratory chest radiograph, the lung becomes smaller and denser, and the pneumothorax remains the same, thus making the pneumothorax easier to identify. But if it is impossible to identify in radiograph, then we should still request for a CT. Pneumomediastinum is the presence of extraluminal gas within the mediastinum. Gas may originate from the lungs, trachea, bronchi, esophagus, and peritoneal cavity, and track from the mediastinum to the neck or abdomen. It commonly results from blunt or penetrating chest trauma, or maybe secondary to neck, thoracic, or retroperitoneal surgery, or even perforation of the esophagus or trachea. These are chest radiographs, PI lateral views. You see the blue arrow points to a linear lucency under the mediastinum, and it is continuous from right to the left hemidiaphragm. This is the continuous diaphragm sign. The red arrow, meanwhile, points to a lucency at the inferior cardiac border. This AP radiograph demonstrates pneumomediastinum outlining the left subclavian artery and possibly the left carotid artery, and is called as the tubular artery sign. Another lateral radiograph demonstrates the ring around the artery sign, which is seen on lateral chest radiographs as a well-defined lucency along or surrounding the right pulmonary artery. The Nacclerio V sign is a sign described on the plain film in patients with pneumomediastinum occurring often secondary to esophageal rupture. It is seen as a V-shaped air collection with one limb outlining the left lateral mediastinal border, while the other limb between the parietal pleura and left hemidiaphragm. The Spinnaker sign is a sign of pneumomediastinum seen on neonatal chest radiographs. It refers to the thymus being outlined by air, with each lobe displaced laterally and appearing like spinnaker sails. It is distinct from the sail sign appearance of a normal thymus. So can you identify the critical finding in this radiograph? Okay, so the ET tube is too low. The tip of the endotracheal tube is in the right mainstem bronchus. So this is a critical finding, and you need to relay this right away because right mainstem bronchus intubation will lead to atelectasis of the entire left lung and hyperinflation of the right lung. Most often, endotracheal tubes are malpositioned in the right mainstem bronchus because of the shallower angle of the right main bronchus makes the trachea than does the left mainstem bronchus. Here's another radiograph showing a malpositioned ET tube. In this case, the tip is at the bronchus intermedius, and this is much lower compared to what I showed you a while ago. Bronchus intermedius intubation may lead to atelectasis of the entire left lung, the right upper lobe. Here's another malpositioned tube. A linear opacity seen coursing the midline, and it made a loop going up, and tip is seen at the level of T2. This is a malpositioned feeding tube. In this radiograph, the feeding tube is not inserted to the adequate length, so further advancement of the NGT is needed for this patient. The ideal position should be in the subdiaphragmatic position, identified on a plain chest radiograph as overlying the gastric bubble. Ideally, it should be at least 10 centimeters beyond the GE junction. Here you have a chest PA view with a large rounded opacity or focal bulge with rim calcification at the region of the aortic knob. This finding is highly suggestive of an aortic aneurysm. Although without a vascular calcification, this may also suggest a superior mediastinal mass. A thoracic aortic aneurysm is the ballooning of the upper aspect of the aorta, which is above the diaphragm. And the term aneurysm is used when the axial diameter of the thoracic aorta reaches or exceeds 5 centimeters. On chest radiograph, the most common finding of aortic aneurysm is not really focal bulge, but just widening of the mediastinal silhouette, enlargement of the aortic knob, and tracheal displacement. In aneurysms may be complicated by dissection. Aortic dissection is the most common form of acute aortic syndrome. It occurs when the blood enters the medial layer through a tear in the intima and tracks along the media, form a second blood-filled channel within the wall, and patients may present with anterior or posterior chest pain and a tearing sensation in the chest. And CT angiography has a reported sensitivity and specificity of nearly 100%, so it has to be done in patients with suspected aneurysm and dissection. Complications include abdominal organ ischemia or embolic stroke. And in some cases of aortic rupture, especially those involving the ascending aorta, the involvement of the coronary arteries may result in infarct or occlusion, so it may be warranted to do dedicated CT of the coronary arteries in this case. It is also imperative to do 3D reconstruction, as shown here. So let me show you another critical finding more often found in young children. This blue arrow points to an opacity. Actually, this is a foreign body, an earring to be specific, which is lodged in the right main stem bronchus of a 25-year-old. Again, the right main stem bronchus is a common location due to its posterior location, shallower angle to the trachea, and wide diameter. With non-radio-opaque foreign bodies, indirect signs of aspiration will include focal overinflation or atelectasis. Another critical finding is severe narrowing of the airway, like in this case resulting from a large lobulated thyroid mass. Lastly, pulmonary embolism refers to embolic occlusion of the pulmonary arterial system. The majority of cases result from thrombotic occlusion such as DVT or deep vein thrombosis, usually coming from the lower limbs, and these are depicted as filling defects within the pulmonary arteries in a patient with dyspnea, chest pain, and even hemoptysis. So you have gone through the most common and important critical findings in the chest, which we cannot miss during our duties and should warrant rapid communication with the radiologist or clinician in order to add value in patient care. These are my references. Thank you very much for your attention. I hope you learned something today.
Thank you very much, Dr. Gerald Garvin Lim. So now let's proceed to the second speaker, and let me introduce her to you. Dr. Lara Gabriel L. Lim is a board-certified radiologist, and she obtained her medical degree at the University of Santo Tomas, Faculty of Medicine and Surgery, Manila, Philippines. Her postgraduate internship at Chinese General Hospital and Medical Center. She then had her residency in general diagnostic radiology at the University of Santo Tomas Hospital, and has recently concluded her fellowship in CT/MR imaging in St. Luke's Medical Center Global City, Taguig, Philippines. Dr. Lara Lim has presented various research papers, case discussions, and publications, and special interest in breast imaging and abdominopelvic imaging. She will be talking about actionable findings in abdominal imaging in this session. Ladies and gentlemen, let's welcome our second speaker, Dr. Lara Gabriel Lim.
Good day, everyone. Thank you for having me today. We are going to be talking about actionable findings in abdominal imaging. I have no relevant disclosures for this talk. Let us begin with a quick view of the objectives of this presentation. We will start off with an introduction of the concept of actionable findings in medical imaging, categorization of these findings, and finish with a few examples of findings from each category. Let us begin. The American College of Radiology Workgroup defines actionable findings as imaging findings that require non-routine communication with a referring physician because of urgency or unexpectedness of a certain result. Both the radiologic technologist and the radiologist play key roles in identifying these findings in daily practice, as not recognizing these critical results may inadvertently delay treatment and lead to patient morbidity. This is particularly important in asymptomatic patients who come to the imaging center with incidental actionable findings detected on routine imaging. The ACR work group categorizes actionable findings into 3 sets, based on severity and level of urgency. Category 1 findings generally require non-routine communication within minutes of detection. Category 2 findings within hours, and Category 3 findings within days. It is important to acknowledge the vital role of the radiologic technologist here. The radiologic technologist is the very first member of the imaging team to see the diagnostic images of a patient and has the opportunity to alert the radiologist to the presence of an actionable finding. Please keep in mind that some actionable findings may fall in a gray zone where different institutions categorize it differently, perhaps due to differences in experience or prevalence of a finding in their local setting. Now let's begin our discussion with Category 3 findings first. Category 3 findings, although unexpected, generally do not require immediate treatment. Follow-up imaging is still needed, but not for a few months, and non-routine communication can be done in days or weeks. These include findings such as incidental probable malignancies or a non-malignant finding that still requires long-term follow-up. Findings placed in Category 3 should not pose an acute danger to the patient. Findings that pose acute danger to the patient are either placed in Category 2 or in Category 1. Category 2 actionable findings are clinically significant observations that require non-routine communication with the clinical team within hours of detection. While more urgent than Category 3 findings, actionable findings in this category do not pose the same degree of severity of Category 1 findings. To help explain this better, let us look at some examples. Ascites. Low volumes of ascites are often placed in Category 3. However, significant volumes of ascites warrant more urgent clinical attention and are placed into the Category 2. Ascites can be transitive or exudative, based on their etiology. Here we have a 60-year-old male with significant amount of hypodense fluid collection within the abdomen. On review of his clinical history, he was found to have cirrhosis and hepatitis C. This is a case of transitive ascites. Intraperitoneal fluid collections can be hyperdense when it has hemorrhagic content. This patient was a 40-year-old female who came in with a week-long complaint of nonspecific bloatedness. She denies any trauma to the abdomen. On non-contrast abdominal CT imaging, there was a sizable collection of hyperdense fluid within the pelvis, between the uterus and the rectum. This imaging finding was relayed to the clinical team and further workup was done and the patient was managed accordingly. Category 2 actionable findings also include intra-abdominal infections, as these require urgent treatment. These 2 patients came to the imaging center with a complaint of right lower abdominal pain. Axial non-contrast abdominal CT at the mid portion of the abdomen shows a marked stranding of the intra-abdominal fat around the colon. This was a case of acute diverticulitis. In this second patient, axial non-contrast abdominal CT of the lower part of the abdomen shows a bowel look-alike with a lot of fat stranding surrounding it. This was the inflamed appendix in this case of acute appendicitis. Both of these examples highlight an important point. In abdominal imaging, fat stranding is a reliable clue to intra-abdominal infection. Even if junior members of the imaging team are unsure of the pathologic organ, junior members of the imaging team should be encouraged to alert senior members of the staff to the presence of definite intra-abdominal fat stranding, as this is a good indicator of a Category 2 actionable finding. Let us look at a few more examples. Our next patient is a 52-year-old male who had otherwise been feeding well until after he had awoken that morning. On contrast abdominal CT, fat stranding was seen around the pancreatic head. This was a case of acute pancreatitis. How about this second case? This was a 22-year-old male who had left-sided abdominal pain. The ordering physician had requested for a non-contrast abdominal CT because he was quite unsure of the patient's diagnosis. The scan showed fat stranding around the left kidney, explaining the patient's left-sided abdominal pain. MRI scans also show intra-abdominal fat stranding quite clearly. Here we have a 72-year-old female who had what she claimed to be an odd feeling in her stomach. T2 weighted imaging with and without fat suppression shows fat stranding as hyperintense signals around this very much inflamed gallbladder. There is much more evident fat stranding in the fat suppressed image. Notice that there are also fat stranding hyperintensities outside the abdomen in the right side of the abdominal wall. This was a case of acute cholecystitis. Finally, we have Category 1 actionable findings. These findings can lead to death if not acted upon in a timely manner. Direct verbal communication with the clinical team is generally required within minutes of detection. Our first example is unexplained pneumoperitoneum. Air is normally seen within the bowel loops. Pneumoperitoneum is extraluminal air and calls for surgical management. In this first case, we have a 50-year-old male patient with abdominal pain. Here we see this very hypodense collection in the non-dependent portion of the abdomen. This is pneumoperitoneum. Images of the lower abdomen of this patient showed that he had acute diverticulitis that had ruptured. Do keep in mind that some patients, particularly the elderly, may present atypically and without symptoms, and you might catch an asymptomatic patient with pneumoperitoneum. Here we have a second patient. This time he is a 30-year-old male that had been complaining of recurrent right lower abdominal pain. This non-contrast CT of the abdomen is set in the lung window. Using the lung window, we more easily see these tiny air locules within the left upper quadrant of the abdomen. Images of the lower abdomen of this patient showed that he had benign pneumatosis coli. Remember, even if the primary disease is benign, unexplained pneumoperitoneum is a Category 1 actionable finding and should be relayed to the clinical team as soon as possible. Another Category 1 actionable finding is intestinal obstruction, particularly one that shows decreased blood supply to the affected bowel loops. Let us look at two case examples. This first patient is a 60-year-old male with abdominal pain. There are dilated small bowel loops in the low-mid abdomen of this patient. Pointed by the blue arrow is a point of transition from dilated to focally narrowed bowel. The second patient is a 65-year-old female with similar symptoms. This time, though, there is much more diffuse involvement of the small bowel loops. A focal point of transition from dilated to narrowed bowel is also pointed by the blue arrow. Both of these CT studies are contrast enhanced, but the difference of these two case examples is the degree of bowel wall enhancement. In the first case, there is clearly decreased enhancement of the affected bowel loops. This suggests decreased blood supply of the affected bowel and is in need of immediate intervention, clearly a Category 1 actionable finding. In the second case, although much more of the small bowel loops is affected and dilated, all of these enhance uniformly. There is no immediate threat to bowel integrity. Institutions may choose to put the second case into either a Category 1 or Category 2 actionable finding. Active intra-abdominal bleeding is another example of a Category 1 actionable finding. This example case is a CT angiogram of the kidneys in a young male who had a motor vehicular accident. The different phases of the CT angiogram clearly shows contrast extravasation from the left kidney parenchyma into a large subcapsular hematoma. Contrast extravasation from large vessels like the aorta and aneurysms of the aorta are also Category 1 actionable findings. We end this presentation with some concluding statements. Actionable findings require non-routine communication with the clinical team to prevent delays in treatment and patient morbidity and sometimes mortality. Categorization of findings is based on severity and urgency, but these are only guides and not rules. Actionable findings may be present in both symptomatic and asymptomatic cases. The radiologic technologist and the radiologist play key roles in communication of these actionable findings to the clinical team. Finally, I end with this statement from the ACR workgroup. The ultimate judgment regarding any specific course of action must be made by the physician involved, with particular knowledge of the condition of the patient and the practice environment. Thank you very much for your attention. Have a good day, everyone.
Thank you, dear speakers. I'd like to call back again our presidents and our panelists. But while we are waiting for them to open their cameras, may I greet and welcome the president of Taiwan Association of Medical Radiation Technologists, TAMRT, President Chun Yuan-Tu. President Tu. Oh, so we can now see President Denise Chu from Singapore Society of Radiographers. Hi, Miss President Denise Chu.
Hi, good evening, everybody. I'm sorry I was a little late, but it's so really nice to see everybody here for the 14th Asia CPD. And thank you very much to our two very clear speakers. Their presentations are very good and very easy to follow. Thank you, doctors.
And attending for PARI President, Indonesian Society of Radiographers, Mr. Putu Adi Susanta.
Yes, thank you, Pichi. I hope my voice clear. So our president, Dr. Pugianto, cannot present. So I would like to thank you to all presidents and delegates. Well presentation, and I learned so much from these topics. So thank you, Pichi, and thank you all presidents. Thank you all delegates.
Yes, thank you, Sir Susanta. So welcome back again, everyone. I'd like to call the panelists and welcome your questions here. You can just unmute your microphone if you want to start with the questions. Or I can start with question. All right, so while we are waiting, I'd like to address one question for Dr. Lara Lim.
I have a question for.
Oh,
first.
yeah, okay, sure. You first, sir.
Yeah, I have a question first for Dr. Giron. I see you have a lot of imaging. I think you were your presentation, your lecture very nice. And my question for you, most now in most Israel technology now they have a new technique like a subtract everything. I want to ask you, how about your center? Like for example, in my center, the first and most not normal in check X-ray. The most radiologist in my center they have a request, please move to CT6. They have a request for CT scan again for check something, because a CT scanner for many information for present for doctor. The first question. How about in your center? It most like in my question, like in check X-ray now, like in my screening, and then in most radiologists, they only use a check X-ray for like in screening. If ever not normal, they move to in. They request to move to in CT scan for check again everything. The first question for Dr. Jeroen. The second doctor for Jeroen, I see in your presentation have a pulmonary embolize. I don't know how about your center. After the COVID-19, some people have embolized the pulmonary arterial. How about in your center? You usually for CT scanner for pulmonary in for checks embolized or not embolized in pulmonary arterial in your center. Okay, the two questions for in general.
Okay, thank you, Mr. Taiwan Lok, for those questions. So, for the first one, yeah, it depends. It's the same in our institution. There is the clinicians when they would request for imaging findings. Number one, there should always be an indication on why they will be requesting either an X-ray or a CT scan. As we know, there are a lot of things that we can see, for example, in X-ray, but we can clearly delineate in CT or even in MRI. So, but if ever, for example, the request is not very clear, we usually do call them and then we confirm if what particular finding they would want to confirm in the imaging study. So for the second, during COVID, yeah, we see a lot of pulmonary embolism, especially during the alpha and the beta variant waves, but not much in Omicron. And during those times, as when it was starting, the clinicians would usually base it on the blood test. They would do D-dimer, and then if the D-dimer, the blood test came out to be very high, the level is very high, they would proceed with CT scan to confirm if there is really pulmonary embolism. Now in our center, we use multi-detector CT, and the scanning is usually, it has to be, you have to use the thinnest detectors available. So that's around 0.625 millimeters with smooth reconstruction. And I believe most of the centers are already have this technology. But usually, for example, in the Philippines, in far-flung places, the scanners are not quite old. So in those cases, 1.25 millimeter thick cuts are already sufficient. So of course, we have to make sure also that the contrast injection has to be rapid. It has to be 5 milliliter per second, and the scanning has to begin from the pulmonary arteries and the left atrium is opacified. This in most scanners, you already have the automatic triggering capability. So the delay is also important. You have used the delay of around 10 to 15 seconds if the pulmonary artery opacification is used. So usually in the clinical side, what's important in the clinicians, for the clinicians, are the involvement of the main pulmonary artery in the right and the left pulmonary artery, not so much with the smaller branches. But of course, it is our duty as radiologists and radiologic technologists, of course, to give them the best quality images and best interpretation that we can.
That mean in I think the second question in Dr. Yiran, you told me in Philippines now also, if for example if patient have a D-dimer have a higher value, you must check the pulmonary arterial embolized pulmonary arterial.
Yes. Yes.
Yeah, I think yeah. Okay, thank you, Dr. Yiran. I have a two questions for Dr. Lara. The communication teamwork for diagnosis in very important, very important. I want to learn from you how many people in communication team with one if you see one difficult case, how many people can you discuss in communication? You discuss how many people, how many radiologists, how many technologists you can discuss together, how many people. And I think if my center now we have we not delay in the next day. Most radiologists and technologists in my center, they discuss the communication together in the same day because we have a back system. They have a discuss and the same day by a back system and not only back system, we only send to in cloud for everybody can discuss together. And in my center, I don't know. Usually in my center, usually in the same day we finish and discuss together. We communication team in the same day. But I don't know because in your presentation tell me sometime we spend the next day or next day. How about in your center? You will tell everybody how many radiologists and technologists and communication team. And the first question. And the second question for Dr. Lara. I see in pathology in 2, you have some amazing abdominal infection, abdominal infection. But I see some imaging some case you non-contrast enough for diagnosis. Some case burst in with contrast for diagnosis. My question for you, usually in your center, usually you can, for example, for abdominal infection, in some case you don't use the contrast, with contrast enough, or with contrast enough, but in a contrast enough. When with contrast, when with contrast, some case in abdominal infection. The second question for Dr. Lara.
Hi, thank you, President Taiwan Block. So in my experience, I've been able to work in 2 imaging centers already. In the first center, we had a very small team. So I think in our CT center, we had like roughly 6 or 7 radiologic technologists with us. In our MRI center, we had 3, and then several radiologists. In the second center I was working with, we had a big number of radiologic technologists. But you see, each patient that comes into the imaging center they're only assigned maybe a couple of radiologic technologists, right? So we rely on that smaller team of radiologic technologists to alert us of actionable findings or critical findings in a certain patient. As for the workflow, yes, I agree that most of the time, within the same day, imaging findings are already relayed to the attending physician or the requesting physician or the emergency room team, actually. But there are some cases, especially when the center has a large volume of patients, that category 3 findings in particular are not immediately relayed because there are more category 1 or category 2 findings that have to be relayed first. So we have to queue those, and maybe sometimes if they do reach a second day or a third day before they're relayed to the clinical team. In the smaller center that I worked with before, because we had smaller number of patients, even category 3 findings, we were able to relay within the same day. So it really depends on the practice that you are at. I would like to suggest that most imaging centers should have a meeting or a protocol that they will follow whenever they encounter these findings. So how they will handle it, who will relay, and if the radiologic technologist or the doctor will relay the findings to the attending physician or the requesting clinical team. For the second question, for category 2 findings involving abdominal infections, right? So sometimes clinicians will opt to do or request a non-contrast CT study. It's like a preliminary scan to just see if there is indeed something wrong inside the abdomen. When they reach us and we're informed that there are fat strandings indicative of some sort of abdominal infection, we immediately call the requesting physician and we tell them, oh, we're thinking about that this is a abdominal infection. You might want to do a contrast study. If they do decide to do a contrast study, we'll do that, and that would confirm if there was abdominal infection or something else. Unfortunately, there are patients that cannot go to the contrast route because of, let's say, kidney problem, or maybe they're not stable to do the contrast study. In those cases, if the attending physician thinks that clinically their symptoms do coincide with abdominal infection, they may opt to forego the contrast study already, and we'll manage the patient as a case of abdominal infection with the non-contrast scan.
Yeah. Thank you, Dr. Jeroen and Dr. Lara. After me, today, to doctor for us many information, and thank you so much to Dr. Jeroen and Dr. Lara, many information for us. Thank you so much. Yep.
Thank you.
Thank you.
Yes, so we have a question here for Dr. Lara. Question is, all imaging procedures have generated reports to communicate findings. What is so special about actionable findings?
Yeah, that's a good question. So I agree, all imaging reports will have a final report, right? A written report from the radiologist that's given out to the patient and to the requesting physician. But our discussion today was for actionable findings. And if we follow the American College of Radiology's recommendations, they suggest that we have this form of non-routine communication. That is, we go out of our way to contact the attending physician or the requesting physician to tell them about imaging findings that need urgent actions or urgent treatment, or imaging findings that might be missed out by just simply giving them a piece of paper. So that's the importance of non-routine communication. It's the term to describe the form of communication is non-routine. Like for category 1 findings, the recommendation is actually verbal communication, calling up the physician. If they're not at the ER, or if they're from another imaging center that's not affiliated with our center, the recommendation is for us to call them up to let them know that their patient appears to have this certain condition that requires urgent treatment. So yeah, that's the importance of relaying actionable findings or critical findings in comparison to simple written report. Yeah.
Yes, Dr. Lara, there's a question from the participants here. I think this is somewhat related. His question is about, are you open to having the RADTEX to directly alert possible critical findings to the attending requesting physician as a non-routine channel of communication upon detection? Or would you suggest that radiologic technologists to alert the radiologist to expedite the read on these possibly critical imaging findings?
Yeah, thank you for that question. Yes, I agree that the radiologic technologies has an important role here whenever there's a need to relay actionable findings. But my recommendation would be to inform your clinical team first, because most often certain findings have to be discussed first before they're alerted or they're sent out to beyond the imaging center itself. So I would suggest that you either alert a senior radiologic technologist and then you together go to the radiologist consultant that is on duty so that you can discuss if what you're thinking about is really what's happening inside the patient, or if you have to suggest other procedures that can confirm your suspicion.
Yes, thank you very much, Dr. Lara. And then next we have a question for Dr. Gerald Lim. Yes, so the question here is, how do you relay the critical findings in your institution? Specifically, another question is about the case of pulmonary embolism. A question is, can you give the protocol in your institution for diagnosis of pulmonary embolism?
Okay, thank you. So for relaying the critical findings in our institution, actually it was already discussed by Dr. Lara earlier. So we also follow the American College of Radiology guidelines. So basically upon scanning, the radiologic technologists are usually the first in line to recognize the critical findings. So in the event that there is any suspicion that there may be a pneumothorax, for example, they have to immediately call the resident on duty, whom will then validate this finding together with the consultant radiologist. And we usually call the attending doctor or the clinical service or even the nurse to relay the findings. After relaying, we document it in the PAC system, and then usually we have to relay critical findings within a 15-minute time period. And then ultimately, we do monthly monitoring and audit of compliance with regards to the turnaround time as well. But again, it may differ and may vary from institution to institution. So for the second question regarding the pulmonary embolism protocol, I believe I already discussed this earlier also. So again, we use multi-detector CT in our institution. We use thin detectors, 0.625 millimeter with smooth reconstruction algorithm. And then the contrast has to be injected rapidly in the 5 milliliter per second, and scanning should begin at the level of the pulmonary artery or the left atrium as it is opacified, and then we do 10 to 15 seconds delay. And again, the important thing is that the main pulmonary arteries, the right and the left, are all opacified and are free of motion artifacts as much as possible.
Thank you, Dr. Gerald Lim. Yes, a question for Dr. Lara. Dr. Lara, can you explain why there is a gray zone when classifying actionable findings?
Yeah, okay. So the classification scheme that's given by the ACR is just a recommendation. It's only a guideline. And in their published guideline, they opted not to give black and white table categorization because oftentimes practice experience or a local practice setting or prevalence of disease can affect how conditions are managed medically. So sometimes some institutions may want to treat acute appendicitis, for example, medically with antibiotics, as opposed to some centers who opt to treat appendicitis more aggressively using surgery. So many times also local guidelines, like for example, here in the Philippines, the Philippine Medical Association or the Philippine College of Radiology, they can also publish guidelines that affect only the local practice, the local practices. So these can change per practice setting. So a recommendation in the United States or a recommendation in other countries may not be the same for that in your country. Also, recommendations from another part of your country may not be the same as the part of the country you're in. So it is possible that one imaging center places one condition into category 2, and another imaging center places that condition in category 1. So it really depends on the institution you're in and how the doctors or the clinicians in your institution would opt to treat that certain condition.
And another question for you again, Dr. Lara. Can you give more examples of category 3 findings?
Okay. Okay, so category 3 findings are those findings that can be followed up after a few months from the imaging procedure that they had done. So these are commonly incidental or unexpected benign or possibly malignant tumors that don't have concurrent acute conditions, like for example, obstruction, let's say small liver tumor that doesn't have portal venous thrombosis or biliary obstruction. So the patient does not have any pain associated with it. Or for example, colon carcinoma that doesn't cause bowel obstruction. So again, the patient is asymptomatic, but they do have something, a condition that needs to be worked up later on in the coming weeks or the coming months. And sometimes because the radiologic report, the written report, is simply given out to the patient, sometimes the attending physician may miss out on it, or possibly the patient does not go back to their attending physician right away. There's sometimes a need for us, the imaging team, to go and tell the attending physician using this non-routine communication that we're talking about, so that the physician will be the one to spearhead the workup and not delay treatment, because it's understandable, like if the patient has colon carcinoma and their workup is delayed for weeks or months, by the time that they're worked up, possibly that colon carcinoma has metastasized and the patient has poor prognosis. And this is what we're trying to prevent, the part where the patient develops metastasis or other conditions that complicates things. So that's why category 3 findings include those disease conditions that also require longer term follow-up. So benign conditions that are possibly malignant, we're not really sure yet because the patient is asymptomatic or the clinical symptoms of the patient do not coincide with the tumor. These still require longer follow-up within months or possibly even years. So yeah, those are examples of category 3 findings.
Yes, thank you, Dr. Lara. Another question here from the participants we have from Sherlene Reyes. Is there an instance that when you give a contrast, the aneurysm was triggered or a more serious condition came out? How will you manage if that case happened?
Okay, so usually abdominal aortic aneurysms, they come in the imaging center with symptoms, okay? So also a patient's clinical conditions, like for example, their risk factors or patient characteristics, they also indicate to us that the patient has possible aortic aneurysm. Knowing this, we can scan this patient with the aortic protocol, the aortogram protocol. I have not personally experienced or seen a patient that had known aneurysm that ruptured because of the aortogram protocol. But if a ruptured aortic aneurysm is found on the aortogram, the CD aortogram, these are immediately relayed to the clinical team. Also, in the centers that I have been working with, whenever the patient has a suspicion for a ruptured aortic aneurysm, the emergency room team or the requesting physician has a member of their team there with us when we do the scan, so they know right away that the patient has a ruptured aneurysm and they're sent for treatment immediately.
Yeah, so Dr. Lara, I think you can also read the Q&A section here. The first question there actually is about ruptured aneurysm. This anonymous attendee is asking if it falls under category 1. And if it is it still possible that you inject contrast agent in such case?
Yeah, so it is, yes, it is a category 1 finding and it needs immediate treatment. Most of the time, we do not know that the aortic aneurysm is ruptured. Okay, so when we do the aortogram procedure, we inject the contrast, and that's when we find out that it has indeed ruptured. Sometimes when we do the non-contrast part of the study, we see that there are a lot of fat stranding and possibly even hyperdense fluid around the aorta, and that raises the suspicion for ruptured aortic aneurysm, but we need the contrast to confirm this.
Thank you, Dr. Lara. For Dr. Gerald, these are, I think, extra specific questions. This participant is inquiring about other techniques that you use for suspected foreign bodies in airways. And can you also share CT protocol adjustment that you do or onto patient that is overweight?
Okay, so for techniques in suspected foreign bodies in airways, we can also do, just like in tension pneumothorax, we can also do the expiratory phase imaging in X-rays or in CTs. So if the foreign body is obstructive, it will detect air in the air trapping in that particular segment, lung segment. So it will appear more hyperlucent. Because normally in expiratory phase imaging, we expect that the entire lung would appear as ground glass attenuation or would be hyperdense. So we can do that for suspected foreign body. So for the overweight or obese patients, so you can set the reconstruction algorithm to around 2.5 millimeter thick, and most of the time this will reduce the noise of the scan, and yeah, it will be interpretable already.
Yeah, I think this next question is also for you from Can Phan from Vietnam. Question is lateral decubitus chest view is always used for critical care, in critical care, and when do you use it?
Okay, so I do not think that it is always used, but it has to be done if there is always a equivocal finding. For example, in cases wherein the classic features of a pneumothorax or even pneumoperitoneum is not clearly visible on the conventional views of the X-ray. So we have to do the lateral decubitus, particularly the left lateral decubitus. And the principle behind this, again, is that the affected lung in pneumothorax, they would tend to fall away from the chest wall. So if the suspected pneumothorax, let's say it's on the right chest should be placed up, and that's the left lateral decubitus, right? And when the suspected pneumothorax is on the left chest should be on the upside, and that is the right lateral decubitus position. So,
Yes, thank you, Dr. Gerald. There is also a question posted in the Q&A box. Why is triple rule out CTA rarely done? Any technique to acquire a good quality image of the aorta, coronary arteries, and pulmonary arteries?
okay, the triple rule out CTA. Actually, in our institution, it's not also routine, and I think the centers that are particularly adept to this are those with cardiac capabilities. So I guess it's more of the cost, of course, and the resource and the availability of the interpreting radiologists at that time. And for the second question, sorry, Ma'am Pichi, can you repeat the second question again?
Sure. The next question is there any technique to acquire good quality images of the aorta, coronary arteries, and pulmonary arteries?
Okay, so for the aorta, it's basically the same with the pulmonary arteries, no? So for coronary, cardiac and coronary CT, it usually depends on the heart rate of the patient. So, but the goal in imaging the cardiac or coronary arteries is that we provide images that has the least amount of motion artifacts. So for patients, it will depend mainly on the heart rate. So for patients with stable heart rate, we can employ prospective gating studies or even high pitch, I believe. But if the heart rate is irregular or there is arrhythmia, or if it's more than 90 beats per minute, we have to employ retrospective gating. The retrospective gating usually delivers a higher radiation dose, but will assure that the images obtained will be satisfactory. Of course, the most important part in any cardiac or coronary CT studies is the breath hold. So the radiologic technologist has to explain the procedure very well to the patients.
Yeah, we have so many questions here in the Q&A box. So from Rocky Estafia, can you please share some management with regards to extravasation on the injection site during power injection?
Okay, so in our institution, we follow a certain protocol or algorithm in managing contrast media extravasation. So of course, when it happens, usually the patient will feel pain. But if the patient, of course, is overweight or obese, or there are certain conditions which they wouldn't be able to feel it, we have to be very alert to after the procedure. We'll be able to see that if there is extravasation. So in those cases, we have to raise the arm. We have to apply ice, and then we have to draw marker on the area of the affected extravasation site. So, and then we have to assess for the pulse, the distal pulses, and then how big is the extravasation, and we have to take the vital signs of the patient. Of course, you have to relay this to the clinical team, and then the attending doctor as well, if they would give additional management. Most of the extravasation, even using power injector, they would resolve on their own. But there are some cases that the patient has to be admitted for further observation. So in those cases, the radiologist or the radiology resident would usually go to the room every day to check on the how's the extravasation if it's getting worse. We may have to refer it to plastic surgery service, but of course that's very rare. And most of the time, especially with the newer contrast agents nowadays, most of this extravasation would tend to resolve on its own.
Yeah, thank you, Dr. Gerald. I think this question is for both Dr. Lim, Lara, and Gerald. Yes, this is from John Carlo Manalo. What would you suggest as an acceptable practice for handling possible critical findings for institutions that do not have a radiologist on deck? Yeah, ladies first.
Okay. So it's uncommon, I think, at least in our local setting here in the Philippines, that there is no radiologist on deck, right? So, but I think each imaging center has to have a head of imaging that's usually more experienced or most experienced in their center at least. And perhaps they are able to consult a radiologist in some form or way to confirm the presence of an actionable or critical finding. And perhaps they can be the ones to call up the requesting physician or the ordering physician. But in such cases, whenever a radiologic technologist is left without the help of a radiologist, I think it is important that it is still relayed to the clinical team. Just make sure that you are able to introduce yourselves and your credentials to make sure that they're aware of the limitations of how you relay it to the clinical team, because at least in our local setting here in the Philippines, I don't think it is still yet allowed by law for the radiologist technologist to do something like that. And also most imaging centers do have a medical director of some sort that has an MD license. So maybe perhaps they're in the best position to relay this to the clinical team. However, again, I would like to encourage that all imaging centers have a plan in place or a protocol in place to handle these kinds of situations.
So I totally agree with Dr. Lara. So it's very rare that we would see that there is no validating radiologist. If in the case, for example, nowadays there's a lot of teleradiology services, there's really no radiologist on duty, we can expedite the interpretation of the results by calling the one that who is assigned to interpret the result. So in order to validate the critical finding first. And in the case that we cannot really contact, for example, the attending physician, there are times that we tell the patient, and I think that's acceptable.
Yeah, I think so that if a center is 24/7 open to admit patients, there must be and there should be a head of the imaging team to accommodate critical findings. And it goes to also with the extended development in the roles of rad techs that can be specified in each facility or center, as what Dr. Lim has mentioned. If your work as an imaging technologist in that particular center requires you to have that role to perform when you admit a patient who is suspected to have or would result to a critical finding, a rad tech must be knowledgeable enough, well-trained, and competent to be part of that communication protocol. with regards to communicating critical findings to attending physician and radiologists. But yeah, in the Philippines, I never heard also facility without a head of the imaging team, a radiologist at least. So are there still questions from the panelists or additional information that you would like to add before I proceed with the closing? All right, so I guess none. But I'd like to encourage our dear speakers to please copy and check some more questions that are more specific about chest and abdominal imaging. And maybe we can also give the email address of our speakers if you want to follow up for the answers to your questions here. Because in the interest of time, we have to cut from here to give way for the closing session. So thank you very much, dear presidents, our panelists and guests from the Philippine Association of Radiologic Technologists, PART. We would like to say thank you to our dear speakers, very young, intelligent, distinct speakers from the Philippines. We have Dr. Lara, who's now in the US, and we have Dr. Gerald Lim still here in the country. I'd like to say also thank you to all the 2,500 registered participants. We are sorry that we only have limits to accept some participants in Zoom, but you are still fortunate to have us live, and you can replay the program via VART channel and PARI. We would like also to say thank you to Dr. Nelson Pasha, who's the head of the St. Luke's Radiology Imaging Institute, to President Rolando Bañares, all our officers, and the organizing committee. We also would like to say our sincere thanks to the VT Healthcare, our sponsor, and to the CPD Asia IT team. This online CPD Asia program is truly a success. Before I end, I would like to call President Thai Van Loc to give us an update of the next 15th CPD Asia.
Thank you,
President Thai
Vici.
Van Loc.
Thank you, Vici. Okay, the first, I want to say more, Vici. Today, not only 2,500, around 4,000. 4,000. Congratulations.
Wow.
In Philippines. Congratulations in Philippines host is this 14 CPD. 4,000. Sorry, like in PG tell with everybody, and we sorry Zoom link cannot not enough for everybody. Some participants cannot join Zoom, and then this afternoon before the 1 hour, before the 2 hours, we send for you by email in YouTube. You can watch in YouTube, and don't worry. In all participants in ASIA CPD today, you can, after you registration for Zoom registration, you make sure you receive a certificate in today by email. And I want to say again, for in Philippines or participant in Philippines, Bichi Luna take care for you, and Macau in my program, and yeah, every country in your society can take care for you in your certificate. And the second, congratulations, Dr. Gerald and Dr. Lara. What do you say? How do you say? A lot of questions for you. A lot of questions. What do you say? Everybody interested after me. You have us. You give us a lot of questions, a lot of idea, a lot of information. I think in next ASIA CPD in this year, we will invite you again. We know you can share for your experience for ASIA CPD for everyone around 4,000 and 5,000 practice in the Asia. again, I want to invite you, you continue, share your experience for everyone. What do you say? A lot of questions, not enough time for Q&A for you. Thank you so much. Thank you. You success. Thank you. And last, ASIA CPD 15 in Vietnam host what day? 20th Saturday, 6 p.m. to 8 p.m. Saturday. 20 again, May, next month, May 20th, 6 p.m. to 8 p.m. Topic, what the topic? The new technology in CT MRI in Korea. Again, topic, very new West technology, CT MRI in Korea. Very important. We would like to invite everybody, all participant today, and all president in ASIA CPD, please support for us 28 May, next month, Saturday. Thank you so much. Please support for us. Thank you so much. Thank you.
Thank you very much, President Tai Van Loc. There you have it, the VART, Vietnam Association of Radiologic Technologies, to host the 15th CPD Asia on May 28, 2022. So again, I'd like to reiterate that all those who have registered using the link, although you have watched via the live broadcast on YouTube, as long as you have registered yourselves, you will be receiving via email your copy of certificate, and for our dear speakers as well. So with that, we would like to see you again in the 15th CPD Asia. Again, I am Peachy Luna, and I say thank you everyone and have a great day.
Thank you, Peachy. Thank you,
Thank you, everyone.
Thank you, everyone.
Thank you, everyone.
Thank you,
Thank you, Dr. Gerald.
Dr. Gerald
Thank
Lee,
you.
Dr. Lara Lee.
Thank you.
Thank you so
Thank
much.
you for the speaker. Very
I'll be
informative.
sending your certificates po. And to the panelists po, I'll be sending certificates. Thank you everyone for your support. Dr. President Chung, President Juan, President Koch, Sir Dexter Rodelas, President Locke, Sir Marco Lam, our CPD Asia IT team, Sir Jerry Pedro Lay, the VT Healthcare sponsors. Thank you very much, everyone. Sir Philip Chung from Hong Kong Radiographers Association. Maraming salamat po from President Rolando Bananas, who's in the far province, far mountainous province. So maybe that's why he really has problem with connecting with the internet. So that's why Sir Dexter has no choice. He has to appear. Yes po.
Thank you. Thank you.
Thank you very much.
Bye-bye.
Good evening from Philippines. Thank you, Sir Dex. Thank you, Sir Marco Lam, VT Healthcare. Sir Philip Xiong, thank you so much. Ma'am Chan Lai Kwan, VT Healthcare. Dr. Gerald, thank you po.